Hello, all, and thank you for joining us today for another Advocate Aurora Health Living Well community conversation. So, COVID-19 has brought unprecedented anxiety to individuals in the communities that we serve, as the most vulnerable often have the least amount of access to information, resources, and care that they need to stay safe and healthy. So, October is Domestic Violence Awareness Month, and today we're going to have an enriching dialogue on domestic violence, also known as intimate partner violence, and its impact on our community. New estimates from the United Nations Population Fund suggest that 3 months of quarantine will result in a 20% rise in intimate partner violence throughout the world. That is at least 15 million additional cases as a result of COVID-19. While it may appear that things are slowly going back to normal for us, the effects of COVID on our communities continue to isolate and keep victims of violence in homes that may not be safe and experiencing higher rates of domestic violence than ever before. This isn't only an issue for our community, this is really a worldwide health issue. As we further discuss today's topic, our communities and patients' health and safety is our highest priority. The Advocate Aurora Safe Care Promise provides additional safety measures regarding masking, social distancing, screening, virtual check-ins, and enhanced cleaning to protect you and your team members. Whether it's in person or online, we are here for you. So a few housekeeping notes for today. All participants have been muted and video has been disabled so we can effectively manage the sound and have the best recording. Throughout the session, please feel free to enter your questions, your comments in that chat window. We have a moderator who will track your posts and we will do our best to answer them in the question and answer portion of this webinar. So at this point, let me introduce today's knowledgeable and wonderful panelists. We have clinical expertise from Advocate Aurora Healthcare and community partners joining for today's conversation. First, we have Andrea Grant. She is the nurse case manager for domestic violence, our Safe Mom, Safe Baby program at Aurora Sinai Medical Center. We also have Antonia Vann. She is the chief executive officer for Asha Family Services. And we have Carmen Pitre, president and CEO of Sojourner Family Peace Center. So we're going to go ahead and begin, and I'm going to start asking just a few questions and allow each of you an opportunity to answer. The first question, and we'll go in order of me introducing you, is can you discuss your field of expertise in domestic violence? What is the work that you're doing? If you can just share a little bit about that work with our virtual group.
Absolutely. Thank you, Sharain. So I always like to say, I think that the foundation that led to my expertise in domestic violence probably started in a space long before I started working in the positions that I'm currently working in. It was very much through real life experiences that I think I was drawn to this work. And so as a nurse, I began my formal training in a specialty area of nursing called forensic nursing. And that's the area of nursing that where we supportively really care plan with patients who are identified as survivors of sexual assault or domestic violence. So we really act as that vital link between the healthcare system and the law system. So I also have the privilege of serving, as you stated, as the RN case manager for the Safe Mom, Safe Baby program. And in that program, I get the opportunity to work with moms who are currently pregnant or who have recently delivered. And they're kind of going through it. They're experiencing domestic violence at different levels. And we kind of meet them wherever they are, and we get the opportunity to support them throughout their healthcare journey.
That's wonderful. Thank you so much. Antonia?
Thank you.
My journey into this field of domestic and family violence or intimate partner violence began over 3 decades ago. And my formal training in that particular area began as in the restraining order clinic at the former Task Force on Battered Women that is now the premier Sojourner Family Peace Center. So, and we were dealing with 11, 12, 13, 1,400 domestic violence restraining orders every single month. So I had some significant training while at Sojourner. And from there, we went under the umbrella of Harambe Ombudsman Project, and we were located right in the community. But under task force, we were doing working with victims within the community, and right at the same time, under the former Department of Corrections regional chief is Jan Cummings. That was Jan Cummings. And under her, we contracted with them to do work with women that were involved in the sex trade industry. But we knew that there were segments of that population that were trafficked. And so those works began, back in 1987, 1988. And then we sprung off from there to establish a standalone entity. And we were written into state legislation in 92 as a culturally specific domestic violence program. And we're still the only African-American culturally specific program in the state of Wisconsin. And we're also one of the first in the nation.
Wow, thank you. Carmen.
Yes, thank you, Sharain. It's an honor to be here with Antonia, you, and Andrea. So thank you for having me as part of the conversation. My training began, I grew up as a kid in a violent home, so I know what it's like to live in fear and in chaos and the uncertainty that violence creates, the physical harm as well. Never wanted to go into this work, but I fell into it about 35 years ago. There's always been an element, I believe that this is a human rights issue, that women, men, and kids, Article 3 of the Declaration of Human Rights says we have the right to live in safety and security. And so I never had that as a kid. And I fell into this work, and there's always been an element of addressing violence against women in my work. I've been at Sojourner 18 years. Prior to that, I was at a federal project and running the Commission on Domestic Violence and Sexual Assault before that, trying to bring my thinking and my lived experience along with others to trying to address the problem of intimate partner violence. At Sojourner, we operate in 3 basic areas. One is crisis housing, Sojourner Truth House. We shelter about 600 women and kids a year, and we have a 24-hour hotline. We take about 18,000 calls on that hotline a year. We do systems advocacy, as Antonia said. One way to get trained is to really jump into trenches, and we help with about 4,300 restraining orders a year. And then we have individuals, so we're in criminal court, civil court, trying to help people navigate those systems. And then we do individual support in a variety of ways. So altogether, we serve about almost 12,000 individuals a year.
Wow.
Before COVID. So.
Well, thank you so much. And I hope our audience has a chance to get a sense of the years and the richness of the experience that you panelists come with. So thank you for sharing that. So one question that I wanted to ask is, how can we improve knowledge in our communities about domestic violence and make sure that there's enough people that are able to support and encourage people to get help? Andrea, would you start?
Yeah, I think when we talk about improving knowledge, I think it's really important that we focus on presence. And the reason why I say presence is because a lot of times you have people who you are privileged to be in front of and to speak with, and you get the opportunity to be a part of their lives. And we have all this information that we want to give to them. And we have all of these resources that we want them to have, and we want them to utilize it the way, we feel like would be in their best interest. But the reality is that a lot of times the knowledge that we want them to have, they may not be in the space that they're able to receive it. And so we really have to, I think, work on that presence, what we are when we first meet them, because you get that first few seconds when you're in the presence of someone, right? It's know me, like me, trust me. Within the first few minutes, a person knows who you are and if they're going to listen to you. They're either closed off to you or they're open to you. And I think that it is really working on creating a space for them to receive. And not only that, but creating a space that even if they're not ready to receive the knowledge that you want to give them during that time, that you think could benefit them along their paths, I think that it is really important to be that warm, receptive presence so that when they are ready, when they come to a space that they are open to taking the next step on their journey. When they're there, I think that then they'll come to you. They will call you. They will reach out to you. They will remember, and then they will be open to that knowledge base. So I think in general, when it comes to how can you remain open or how can we continue to spread that knowledge, it is, to me, I think one of the key things is that. Mm-hmm.
Thank you.
And I can just add to what Andrea is saying. We can improve knowledge in our communities by designing and implementing messaging specific to communities. For example, data indicates that messaging to reduce, for example, HIV and AIDS, for among the populations it was designed to message to, it did. However, it did little in particularly communities of color. Similarly, and I know Carmen remembers this, Carrie Tradewell, the former executive director of the Milwaukee Women's Center, conducted a study and learned that messaging for domestic violence needed to be culturally specific to those communities to be effective. So we need to create messaging specific to those populations intended and do so in a way that is usable for those communities. And sometimes a lot of our experience is that we have to actually break things down. For example, and I know Carmen did similar, we did a lot of stuff similarly. We had to just say what domestic violence was. Hitting, kicking, punching, you have to exactly say what those elements are. And then you have to talk about the different characteristics. So I think messaging is really important in increasing knowledge within the community. We had a major campaign that we proved its replicability, and it was called It's Your Business. And that It's Your Business campaign was, you would hear people in the streets saying sound bites from that. There was a thing called 2020. So 20 eyes coming and 20 feet. And so that kind of messaging that is repetitive, and it speaks to the population that you're intending for it to speak to.
So what I would add is I agree with Antonia, messaging is critical. What I would say, Andrea, I think you're exactly right. People need others to hold space for them when they're wounded or hurt and they need to heal. And we have to be able to hold space with love and dignity and respect. I often say to staff, the most important thing we do is we treat people with love and dignity and respect. Maybe that's all we can do for them in that moment. And so I think that that's critical on a one-to-one basis. And I think, the antidote to violence, I think, is human-to-human contact, person to person, in terms of healing. And I absolutely agree with Antonia about messaging. Some of the notes I jotted down is I think we need more coordinated outreach in our schools, in our churches, and in our community center settings. You know, if you look at the old coordinated community response model that came out in the 80s, it really showed you a wheel with everybody's role, and everybody has a role to play. The medical profession, our government leaders, our schools, our churches. And I think we need a coordinated effort, and we need clear messaging about what the issue is and the role that everybody can play in opening a door for survivors. I kind of think of this work as opening a door for people to walk through when they're ready. If we give them autonomy and allow them to self-direct in their own lives. The other thing is, I think we drop the ball a lot with our young people in terms of offering presence. And I think it's long past time that we have mandated DV education, K through 12, in all of our school settings, in all of our curriculum. You know, there's research from the AODA field that says when you integrate information into the ongoing curriculum, not just one-off presentations, kids are more likely to integrate it. So those are some of my thoughts about outreach. We're beyond the state of emergency right now in terms of the impact that, like you said, 15 more million cases around the world. We're seeing that in Milwaukee, that increase, and it's deadly. And so coordinated messaging, clear messaging, and presence for people, I think, is critical.
Thank you so much. I think that question kind of spurred me to ask another question and kind of get a sense from all of you, if you can help educate the audience about that. What does domestic violence look like? How do I know if my sister might be in a relationship that might be violent? What would I expect to be seeing?
So I can jump in. I think domestic violence looks like different things for different people. It's not always one image of this is the face of domestic violence, right? Because we know domestic violence affects people at different socioeconomic states. Yes. It affects different races. It has nothing to do with your financial status. It has nothing to do with any of that. We know domestic violence looks different and comes in multiple forms. You can say, from the healthcare perspective, you can say, okay, well, domestic violence might be her stories, he or she, their stories are not adding up to maybe marks or bruises that we're finding on their body, right? Domestic violence could be every time she talks, when I ask a question, before they answer, they're looking over at their partner before they answer. They look over as if permission to speak. Could that be something else? It could be. And many times it's a feeling, it's something that it's worth looking into, right? It's offering the resources and maybe not so outright way. It could even be in a way where you're offering, or you see those signs, those little things, whether it's not full disclosure that I am being abused. Sometimes it comes in that form. But it's saying things like, hey, you know what? It's October and it is Domestic Violence Awareness Month, and I am offering this particular information to everyone who I'm seeing today. I know it may not apply to you, but maybe somebody you know could use it at some point.
Yeah.
I like that. Thank you.
When I used to teach, I would say, it's a pattern of coercion and control that one person uses against another in an intimate relationship. And it can include physical, sexual, spiritual, emotional abuse, and it can be subtle to severe. We most often think about people with injuries, but some of the most lethal cases have no injuries involved before the homicide happens. That's what the LAP protocol has taught us. So it could be name calling, criticizing, controlling what you wear, where you go, who you're with, whether or not you have access to money, shaming you, shaming your body, criticizing you in front of family members or children. Punching, slapping, pushing, all the stuff that you would typically think of when you think of violence. But there's a lot of coercion and control that happens. Like you said, Andrea, looking over as if you need permission to be able to speak as an autonomous human being.
And can you talk also about isolation in relationship to domestic violence?
What did you
I'm sorry. I was asking in your response, if you could also address the isolation component. I don't think we've talked a lot about that.
I think
Oh, absolutely. And that's part of the pattern where where the bonding in a relationship takes place. And part of that is pulling that person from their support system. You know, to summarize the state statute, it is the intentional infliction of or threat to inflict physical pain, physical injury, illness, impairment of physical condition, or sexual assault or sexual contact without consent. So that's what the state statute says it is. But you will have populations or groups of victims in particular, particularly those that will fight back. You have a younger population that because they fight back, they don't see themselves as victims. And so they don't identify with that. So even with what you will talk about instances of where, for example, we've talked to families of homicide, DV homicide survivors. And so what I would do is talk about some elements or some features that might have been there. So there are some things that we know that, and according to the LAP, for example, that certain elements of abuse and violence, they tend to lead towards greater harm or possible death. Strangulation is one. There were instances where we talk about someone that was supposed to be at an event and all of a sudden they're not there, or they're whispering in the phone when you call them, or they have to hang up the phone when you call them. Or what the individual, the abuser, tends to do is pull her from her supports and isolate her from her supports and play themselves as a victim and saying, your friends don't like me. They don't like, excuse me, they don't like me. They jealous of us. They know you got a good man, or, you know, and that serves to pull her and isolate her from her support system.
I would also add, Antonia quoted the statute. What I would say is there's no crime of domestic violence. There's a series of crimes that happen within a definition. And the definition is crimes that are committed between two people who lived together in the past, or have a child in common. And so the strangulation piece, what we found with our clients, they don't really resonate with that word, but when you describe the behavior, they're like, yes, that happens all the time. But, you know, that's why messaging, I think, is so critical. None of them say, oh, I was strangled, but they were like, yeah, he puts his hand on my neck, or he choked me, or so back to the messaging piece, it's really critical.
And it is, and that's really significant. And one of the things, a friend of mine that does, Casey Gwynn, he's got one of the largest justice centers in the country. And one of the things that he said is that men who strangle women are women killers, and that they're the most dangerous man on the planet. And so they've got recent data that talks about that. I was sent a text telling me that, you know, Miss Vann, they looking for you on Facebook, you know. And I get on Facebook and there's a picture of a woman, young woman there that someone is saying she needs help. But in pulling this picture up and looking at it, this girl had petechial hemorrhage in her eyes. And so I'm like, has she been to a medical facility, or has, you know, it's like, I'm telling them, okay, I got it. Take that picture down. And then I immediately called Liz over at Sojourner, and at finding out that this woman's abuser was let go. He said something to the law enforcement that said, you know, she's a prostitute, she's this, she's that. And anyway, he got a minor charge. But her picture showed me that it was a heightened criminal act. It was a strangulation, most likely. And that advocates had to get this girl to a hospital to be looked at. But as well, we had to get the DA involved to enhance the charges because of the strangulation. And what we're actually seeing and finding is that when we break it down, well, tell me how, did he cut off your air? Or did he, there's cutting off air and then there's cutting off blood. And cutting off the blood flow it is the strangulation aspect. So trying to get this medical information and break it down as much as you possibly can to get somebody to understand that. So no, they don't say strangulation. Yeah, he choked me, or I blacked out, or this happened. So we have to really dig. And that's the kind of messaging for that, not only that age group, but the cultural group where these kinds of things happen.
Yeah, thank you. So on that thread of this is what it looks like, what are some of the barriers that people might be experiencing that are preventing them from seeking help right now? Because I think sometimes people think, well, they must be okay with it because they stay. What are those barriers that are keeping people from seeking help?
I think fear of the unknown, fear of, the violence may go up. At least if I'm in the relationship, I can manage it. If I leave, I have to manage the constant fear of being hurt, increased sense of isolation. So my social connections might not be intact. I'm afraid of the violence going up. Maybe I'm undocumented, or there's a language barrier, or I'm married to someone who has influence or who is a law enforcement officer. I don't have money. I don't have a job. I don't have childcare. I love and support the person, or maybe I have my own mental health concerns. I mean, there's all kinds of, we get this question all the time. Why does she stay? Well, she stays because it's not easy to leave, number one. And there's all these things. And COVID has made that a million times worse.
Harder, yeah.
But that's just, I think, a general overview of some of the things that can be swirling around survivors when they think about getting out.
Yeah. And another aspect that barriers, they can be structural as well. For example, the location of services, the hours, the staff, those kinds of things. Yep. And then there is the ability of that individual to navigate systems. And that has been one of our concerns, that we're hearing so much of that, in particular from victims in accessing different health systems and understanding what they're talking about. And then, victims in the midst of trauma do not often do well navigating bureaucratic red tape systems. And if a system has the potential to re-victimize or criminalize her victimization, that poses a significant barrier as well. And many are dealing with, and she's in the most danger when that's the largest population of victims who are murdered, are those that are in the process of leaving. So she's in the most danger. And then you have another barrier is the cultural issues around calling police, getting systems in their business, risk of, they're going to take my kids. So there's different kinds of barriers. And if I call the police, are they going to kill me?
Right.
I want the violence to stop. I don't want the father of my children dead, so those are those kinds of barriers as well.
I think another thing, just to add to what both Carmen and Antonia stated, is also that it is that trust that has been broken in the past. So when you come into a hospital setting, or when you decide I'm going to call the police, and you have support systems and they say they're going to support you throughout this process, it just takes just one thing that doesn't get followed through on. It just takes just one step towards that leaving for a person not to do what they say they're going to do, and that trust, I think, is shattered. And that I think is a huge barrier too, because a lot of, like, when we talk about domestic violence and we talk about, it's not something that always happens just one time, right? It is a prolonged time, it's multiple times of things happening and your trust being broken and your ability to just kind of get through things. All those things are affected by your experiences. And so I think that that is huge. I think also when we talked about strangulation and we talked about getting people in to actually receive services, a lot of times it's the knowledge of certain things that exist, right? And so sometimes people don't know, okay, he put his hand around my throat and he choked me, but I'm good now, right? Like I'm straight now. But the reality is you don't know that maybe sometimes the effects of a strangulation happen days after, right? It can happen later that evening. It can happen the next day. And you just might not be aware of that. And the people in your circle might not be aware of that either. So those are barriers. And also the people who you are around, and a lot of us, we use our information. We get our information from those closest to us, whether it be our loved ones, our family, and our friends. And as wonderful as our loved ones can be, sometimes they are misguided with the information that they share with us. And that is a barrier, because I have my mom telling me this, and I love her, and she's been in my space and in my corner. I have my best friend telling me this, and I love her, and she's been in my space and in my corner. But then I have this doctor who I've never met, or I have this nurse who I've never met, and she's telling me this. I don't know her. Why should I believe her? That's also a barrier. Mm-hmm.
Yeah, thank you.
For me, what you're pointing to is the way violence becomes normalized. Like a lot of our clients will say, well, that's just our love language. That's the way we love each other. So we have this acceptance of violence that's been normalized for people that get repeated generation to generation.
Yeah.
Absolutely. Thank you. So if there was someone right now that was in a domestic violence situation, and we could be talking about violence to the adults in the household, violence to children in the household, what would you say to them about reaching out and seeking help?
One of the things that I would particularly do, and what we need to do a better job is oftentimes you have individuals within communities that stay locked within those communities. This is just what Andrea was saying, that the information that they're getting is coming from the people around them. But if the people around them don't have the accurate information to give them, they're going to stay locked within the community. For us, Asha is not, and Asha is now, we're the Asha Project. We evolved into the Asha Project, and we are one of the 4 entities under the under the state coalition in domestic abuse, Wisconsin. So we have NCALL, the National Clearinghouse on Abuse in Later Life, Dare to Know. And then we have our culturally specific services here in the city. But we are not a shelter program. However, we provide hotel stays, for example, and we assist with housing. And Sojourners, You Are Not Alone brochure is a great tool. And it offers all the players in particular areas. And so we actually will sit with victims and we'll provide numbers for services. But what is really important for some of that to work is messaging, billboards, posters within the community that this individual lives, that's at the church, that's at the central health clinic, places that they go. And we saturate the areas that people will go to be able to inform those who are around her, say, you need to call Asha, you need to call Asha. Or wherever, whatever community they in. And so we work with the shelters. So then we sit with someone and we'll call Sojourner, we'll call Waukesha Women's Center, and we'll call other programs to see how we can get space, but we're able to put someone up, for multiple days. At one time we had transitional housing, long-term transitional housing, which was up to 18 months. For a victim in housing. We had 15 transitional housing units, which was very costly to provide that kind of support, because in many instances, we need to have that monitoring the sites. So, but if we will sit with a particular victim and we will make appropriate referrals. For example, if it's a Muslim woman, we're going to connect them with the Muslim Women's Association. If it's a Hmong client, we're going to make sure we call HAWA, the Hmong American Women's Association. For shelter services, we're definitely going to call, Sojourner or the Waukesha Women's Center, or put them in housing. We've had to relocate a number of clients. That requires us to contact program or coalitions or programs in other states to be, and then have transportation established to move this victim, particularly those that are in significant danger, and out of harm's way.
Thank you.
I think survivors, what I would add to what Antonia said is, I think survivors need to know that they're not alone. First, I think you need to hold space for them in a non-judgmental way, because I think survivors, we live in a victim blaming society where victims are constantly being told it's their fault. And I think they need to know, once they feel safe, that they're not alone and that we're here to help. And then, it's a process where you begin to talk about safety and reality. Not all clients can go into a shelter, want to go into a shelter or a hotel. They want to live in the context of their daily life. And that's really a relational conversation that happens around their safety. And I think survivors need to know that reaching out could save their life. One thing about LAP, we've been doing it for over 5 years, and survivors have said, when a police officer says women in your circumstances are more likely to be murdered, when an advocate says that and the DA says it, survivors say they hear it differently. And so messaging, again, is critical. But that safety is really important for survivors. I want to add to what Andrea said. If the first contact a survivor has is judgmental and makes them feel ashamed, that is going to carry forward to every other person she or he deals with. So we will either benefit from the way that first person handled the situation, or we'll be at a deficit because you either are building trust or you're not building trust with that client to walk through the door to safety. And I think that's underappreciated, that whenever you touch a situation, you should do it with kindness and compassion and respect, because the next person they speak to will benefit from that, right? When the survivor's ready, or not benefit from it if I treat that person badly. So, Andrea?
So just in restating the question, it's, if someone is in a domestic violence situation, what do we do to get them, or what do we say to them to seek help, right? When I have a person in front of me or on the phone, I think that I see them as someone who is so much more than what they are experiencing in that moment, right? Yes, they are in a domestic violence situation, but it does not represent who they are. And so from that headspace of knowing that they are incredible beings with a purpose, that when we are kind of putting out to them, you have this option, you can do this. We don't necessarily know how far ahead they're thinking, right? When your battery is on low and it's been on low for some time, it is very hard for you to naturally make decisions that maybe to other people who are running on 100%, those decisions that come very easily, it's not as clear, right? It's harder for you to make those decisions. And so what I say, and I'm able to say with confidence, because I know that this is something they are experiencing. It's not who they are. It is easy for me to look at them with confidence and say, you may not feel it yet, but you have a strength inside of you. It is there. That making the decisions about what's next for you what's best for you can be difficult, and it may take time, and that's okay, right? That for all the times you may have heard that you can't, there is a whole team of people out here that believe that you can, and that help is here when you are ready.
Beautiful.
And that's exactly it. Andrea is exactly it. And there's that difference, that distinction between victim and victimized. You know, letting them know you were victimized, and they have such strength. But for some of them, I think it is really important that people appreciate that domestic violence incidents can span hours. It can span days. And victims tend to be hypervigilant. So they're running at this high pace of vigilance, anticipating something to come. And so that adds to just what Andrea was saying about where they are, what their status is at that particular time. And sometimes when they get to you, they're actually coming down and wanting to feel that they're at a place that they are safe, they're going to be heard, and they're going to be believed, and they're going to be cared for. So that's significantly important.
Thank you. So I'm just going to put it out there to our audience. If there are any additional questions that anyone would like to have answered, please feel free to type them in the chat box while we still have our panelists here to answer your questions. I do want to say thank you so much for everything that you guys have shared. I'm hoping that this information will be useful to somebody, even if it's only one person. We know every person matters. So any other thoughts that either of you would like to close with?
I would say that it's really important for people in the community that are helping, that are in the service industry, if you will, in terms of caring for people, is that they have information. And even if you don't have the words, you know, for example, it's kind of like, you know, we have information that's at different locations. You would be able to give them, you know, the information that talks about what it is and where help is available. I think it's also important that people understand that they can call us at any point in time. And all of us are running something 24 hours where we can get calls. We get a significant number of contacts on social media through that Facebook messaging, through our website. But they're having at least be able to say, well, I don't know what they do, but you can call, you know, Sojourner will do this, or Asha, you know, this number for that number. So that's, again, goes back to the information that we're feeding to the community. So they need to be able to, this needs to be part of the fabric in the community, because this is significant. That the level of domestic violence in this country is pervasive. And so, and people know. So you'll also have, but you also got that element that younger people that have justifications for women being beaten.
Right.
So you got that whole element out there. So but values and beliefs change with incoming information. So that's what makes the messaging so important, and it has to be consistent.
Completely agree.
Yes.
And
Antonia, I think it's also, like you said, like the Asha project, Sojourner at Aurora, I think that being able to have all those options and to be able to plug into different places, because what I might hear from Carmen, I might not receive it. What I might hear from Sharain, I might hear the exact same thing, and it resonates with me differently. So to be open to saying, try this resource. Oh, that didn't work. That doesn't mean that you can't receive what it is that you're looking for. Try this. Try this. So I'm very glad that you said that.
And I think there was a question in our chat that asked the question, is there a race and or cultural component to this discussion? And I do think that it's important for us to acknowledge that. Antonia, I know you had brought that up before.
Is that, yeah, but it depends on if there's race or cultural. There's 8 domestic violence programs in the city of Milwaukee. 7 of them are culturally specific to different communities. There's the Hmong American Women's Association. There's the Muslim Women's Association. There's the Latina Resource Center. There's Diverse and Resilience. There's HER. And there's the Indian Health Center that deals with indigenous populations and work with murdered and missing indigenous women and girls. So there are cultural aspects. And the reality is that because of culture, many people will not come outside their communities. We have the data for that. We already know that. So people are being locked within their communities and are not willing to come outside their community seeking help. So again, it goes back to the piece Andrea was saying, they're going to get information from the people around them. And so if there's messaging specific to those 7 communities, you know, that I just talked about with the 7 culturally specific programs. So those programs might be best for some individuals within those communities. And the reality is that all of us, for example, you know, Sojourner is the big shelter here. So all of us work with Sojourner around getting our victims into accessing a variety of services. However, but you still have that population that will not come outside. So race and culture does matter. And so some of that goes back to some of the things we were talking about earlier, where I mentioned that you have particularly some Black clients, for example. You know, it's like, no, I'm not calling the police. They're not letting them get in my business, or I'm not going to risk losing my children, or I don't want them to kill him. You know, so you have certain things that will impact them in a variety of ways. And then if it's a immigrant family, there's a number of like at the Muslim Women's Association, I think there's 7 different languages that their staff speak to deal with Somali and other populations. And same with Hawa, that deals with, you know, Burmese and other populations. So programs that were designed by and for a specific population may better serve some individuals from within those populations.
I would add to that, you know, we always knew that there'd be some people who would never get on a bus or drive down to the Family Peace Center to receive services. And our intention was, and we should be all collaborating. For Sojourner, you know, we serve 60% of our clients are African-American women, 20% are Hispanic, Latino. And so for us, what's been important is that our staff reflect. So, you know, over 65% of our leaders are professionals of color, and almost 60% of our staff are from these communities. So when you're with us and being served, you see someone who looks like you, and that's been important for us. But we know that there needs to be many doorways for people to walk through. As Antonia said, not everybody will want to come down, especially because sensitive crimes is located in the Family Peace Center building. So in addition to shelter, you know, we do all of the case management and the restraining order services. Yeah. So we have a duty and an obligation and responsibility as Sojourner to make it comfortable for clients from different cultures to be able to come forward. That's really important. And then to collaborate with other programs that are serving people in their own communities, in their own neighborhoods. there's more than enough work for all of us to be doing in collaboration.
Agree. Another question that popped up in the chat box, and Carmen, maybe you can start with this one, is how are staff and advocates on the front line trained to work with people experiencing domestic violence and mental health substance abuse disorders?
That was a great question. I saw that question in the chat. So most people come to us with some sort of either lived experience in their work life, in the field, or where they've been trained and have been working and practicing for a number of years, or they come to us with a criminal justice or social work background as a foundation. In addition to that, we do consistent trauma training, healing focused care training, motivational interviewing. We have a basic advocacy. You know, you get hired, you don't get to work with your first client for at least 3 to 4 months. You have to go through basic advocacy, shadowing. We have an internal e-learning system where we have videos and sessions that are posted, as well as formal training. We have an AODA specialist that leads alcohol and drug abuse trainings here on site. And we've also invited partners to train. We're just talking about our friend Latrice. We need to bring her in. So I see learning as a constant process for our staff, and we're supporting it with wellness initiatives, an e-learning system, and a formalized internal training program that supports people in the field. Because I'm telling you, when you start to do the work, your training is just one piece of what you need intellectually. The work is hard. I don't know, Antonia, would you add to the training piece, or Andrea?
Well, definitely the domestic violence 101, the dynamics, you know, I get training and understanding on what this thing is. And in addition to that, you know, trauma-informed care, doing assessments, doing support groups, group facilitation, or conducting individual sessions. And there is, they role play those different kinds of situations. And so in Domestic Abuse Wisconsin has a significant number of trainings that occur throughout the year on a variety of areas. Our staff go to Carmen's trainings that they have. We hold trainings, particularly around a cultural competency with working with African-American populations. A lot of our training with staff has to be about working with African-American populations, or looking at family, digging deep into into structures, traditional families within African-American community. An example is that if, and I always have to say that just because somebody's Black doesn't mean that they can work with Black folks. And that's just a reality. So it is an ongoing training for my staff as well, to have an understanding of not only the historical trauma, but the context that the violence was created in, that added to the domestic violence that is occurring within the community, and that is so particularly widespread due to the data indicating it indicates that individuals in certain housing live in a certain area, that they're more prone to domestic violence because of looking at all the social determinants of health. They're more prone to violence. The violence is more serious, and there's a greater likelihood of death in looking at, you know, who victims are. Our victim population, I think 28% are white women that we see in our program. And that's been consistent across all of our 30 plus years. So, and all of us see different individuals within their communities. So.
Thank you. Andrea, I'm going to direct the next question at you, because I think it's one that you've experienced rather frequently in the work that you're doing. So the question was, as a hospital chaplain, what are key questions that I can ask if I suspect that someone's being abused? Any words, phrases, or behaviors I should look out for? With the no visitor policy in place due to COVID-19, we have had a unique opportunity to reach individuals when their abuser is not present.
Okay, that's a great question. And I know it's coming from a space of really wanting to help and make sure you provide for the patients that you're seeing, the individuals that you're working with. And I would say, I will answer it. I'm going to come around, but I'm going to say, first, knowing that a lot of times the training that we've received and the way that we approach certain individuals, you may not feel like it's in your wheelhouse, that it's not something that you do regularly, right? And so it doesn't mean that you're not helping when you offer or when you bring in other people on the healthcare team that is their specialty. And so if you are building and you're saying, hey, you know what, we have a department here within, I'm not sure if you're in the hospital space, but we have a department here within Advocate Aurora. It is the Aurora Healing and Advocacy Services. And there are advocates and there are nurses who can, if it's a need, who can assist you in any situations or any of your journey along with domestic violence or intimate partner violence. Specific questions that you can ask are, if you're not sure and you're not sure what to say, you can say, hey, are you afraid of anyone right now? Is there anyone who you're scared of? And depending on that response, you can also ask questions about, are there any needs that you're having right now that aren't being addressed, that are outside of what you may feel like you normally talk about in the healthcare setting? Are there any needs that I can help you with? It goes back to, again, creating that space. It goes back to asking those questions. If you are in a situation where you feel like that you need to ask, there's something that you've seen already. There's a behavior, there's something in the communication that your spidey senses are kind of there. Listen to that. Offer the resources. Within our hospital, we have provider cards that really go into some questions that you can ask. And that there's also safety and well-being for domestic violence cards that we have. And I don't know if I think I do have one. They are these, if you can see that. And they also go into help that's available, preparing to leave, safety planning, all things that you can it really outlines it so that you can speak with that person and offer them resources and feel like that you're helping them, especially when you have that time alone with them, whether it be over the phone or in your visits when they don't have any person with them at the visit.
Thank you so much. And we're coming close to time, so I'd like to end with a question that I have frequently been asked. So today I will ask it of you. It did pop up in our chat, but what sustains you as you do this difficult work?
What sustains me, I can say, is when we help people be able to reach a place where they are beginning to feel some kind of security. And that means not being afraid, where they're not that afraid. When you are helping people, when you are teaching people to navigate systems. So I think a lot of that, seeing the impact within victims' individual lives, seeing them grow from the person that stumbled in there and to the person that can feel good about themselves again, and being able to offer, the different supports to where they can hold their head up again. They're stronger. So I love running alongside victims and holding up their arm till they can hold it up themselves. So I love that.
Thank you. That was wonderful.
Andrea, would you like to go or?
Yeah, I think if you remember when we started the talk and many of us talked about what brought us to this work in the first place. And so it becomes a passion project, right? It becomes something that it gives, it doesn't just take. And because of that, you lean on the people who you work with, and you use your support systems outside of work. You make sure that you fill your cup with things that bring you joy, and then you continue to do that passion work that you were called to do. Yeah.
Thank you.
And for me, I believe in a higher power. I believe that there's something bigger, and that this work belongs to that something bigger, that it's not mine, not ours, that I am grateful to be able to show up in service to that. And I believe that people are able to heal, that we have an intrinsic, I've seen it in my own life. We have the ability to heal incredible traumas. And that's way beyond anything I would try to hold on to. So for me, it's just being able to be connected to something bigger and to be able to witness the healing that can happen for people if you are in service to love in particular, and respect and dignity. So that's what builds me up. It is hard work to stand and hold space for people who've been, so hurt in their lives, but it is an honor as well.
Well, thank you so much. Thank you, Andrea, Antonia, and Carmen, for your time and your expertise on this topic as we continue to work to help our communities live well. Thank you for attending today's webinar from Advocate Aurora Health's Living Well Virtual Community Connection. The sessions are recorded and will be sent via email next week. Stay connected with us online. You can use our app and our social media platforms as well. Please be on the lookout for more virtual Advocate Aurora Health Living Well community conversations. And if anyone is out there and needs help, just know that we are here when you're ready. We're here for you. So thank you so much.